Dear audience, dear chair, my name is Petra Papócsi. I'm an oral surgeon and a PhD student at Department of Oral Maxillofacial Surgery and Stomatology. My supervisor is Zsolt Németh and my SMS is Alex. My vision is to learning and utilizing the latest techniques in case of patients with jaw fractures, and my mission is to using a faster and more comfortable splinting method during the night duties. You can see here my specific goals. At first, to investigate the effectiveness and safety of the currently used fixation techniques in treatments of jaw fractures, and my second goal are the maxillofacial injuries related to the e-scooter usage. My first project is a systematic review and the network meta-analysis. Jaw fractures, which involving the dental occlusion, we have to re-establish the occlusion, and that's why we need the intermaxillary fixation. The maxillomandibular fixation word is the same. It's really important for our field because the mandibular fractures are the second most common facial injuries, mostly common in male in their 20s. And these fractured ends must be fixed because if we don't do that, there could be an unproper mole healing. It can cause bite and functional differences, aesthetical and psychological ones as well, and it can cause inflammation. This fixation can be achieved in a conservative way with close reduction and in a surgical way with internal fixation. In the first picture, you can see the Eric arch bar. When we use two arch bars, they are fixed by interdental wiring. It's the gold standard technique. It's really painful for the patient, and it's not so time efficient. That's why they started to use the IMF screws. The IMF screws, as you can see in the second picture, are 4 or 6 self-tapping screws. It's a shorter time to applicate. It's less painful for the patient, but we can cause many iatrogenic injuries with them. In the third picture, you can see the hybrid MMF technique, where we use 2 arch bars, and they are fixed with screws. So it's the synthesis of the previously mentioned 2 methods. And our aim was to compare these techniques and reduce the complications and the surgery time. A clinical question was that is there any difference in effectiveness and safety of the currently used methods in treatments of jaw fractures? Our population were adult patients with jaw fractures who need the IMF. Our intervention and comparator were the Eric arch bar, the IMF screws, and the hybrid MMF technique. And you can see the outcomes on the table. And our aim was to create a time-efficient and safe technique, which is comfortable for the patients and the surgeon as well. We conducted our systematic search in 4 main databases, and you can see here our final search key. At first, we had more than 20,000 hits, and after the selection, we had 29 eligible full texts. We divided the outcomes into safety outcomes and efficacy outcomes. Due to the time constraints, I would like to talk about one and one from each group. At first, I would like to start with the application time. It was measured in minutes. On the left side, you can see the network plot, where we can see the interventions, and the lines are the comparisons. And on the right side, we can see the P-score ranking. The random P-score is higher. It means that the treatment is better. So we can see that the IMF screws were the most time-efficient technique to use, followed by the hybrid technique, and the Eric arch bar was the most time-consuming. In the leaky table, we can see the point estimates and the confidence interval was in the brackets. It shows us that application of the IMF screws is about 47 minutes less than the Eric arch bar, and the application of the hybrid technique is about 33 minutes less than application of the Eric arch bar. So these results are statistically significant and clinically relevant as well. The next outcome is a safety outcome, would be the iatrogenic injuries in relation to patients. I mean the tooth vitality loss and the root injuries, for example, caused by the self-tapping screws. On the left side, you can see the network plot again. And on the right side, the P-score ranking shows that if we use the Eric arch bar, it causes the less iatrogenic injuries, followed by the IMF screws, and the hybrid techniques causes the most injuries because we use many self-tapping screws. The leaky table shows that using the Eric arch bar causes about the third part of iatrogenic injuries, then the IMF screws, and about the fifth part, then the hybrid technique. So these results are clinically relevant and statistically significant as well. You can see here our first project progress. The strengths are that it's the first network meta-analysis which compared these three techniques together. We used homogeneous populations, and we made direct and indirect comparisons as well. But we had small case numbers and various units of measurements, which could be a limitation. In conclusion, we should say that the IMF screws and the hybrid MMF technique are more effective in case of application and removal time, oral hygiene, patient acceptance, but there's a higher risk for iatrogenic injuries and inadequate occlusion. So we would like to recommend the wider use of the IMF screws, but we should discuss with the patient about the advantages and disadvantages as well. And we need more multiple arm studies at the same time under the same condition with higher case numbers. You can see here the current status of the manuscript. Our revision was submitted in International Journal of Oral and Maxillofacial Surgery, and only they asked the minor request from us. My next topic are the maxillofacial injuries related to the e-scooter usage, is the systematic review and the meta-analysis. The e-scooters are really popular. They are the part of the urban micromobility because it's an environmental friendly way to transport, it's highly available, and it's cheap. But there are no restrictions for helmet usage and using them under alcoholic intoxication or drug intoxication, and there are no speed limits, and it's a problem. It's important because the most common injuries are face and head and neck injuries, especially in case of young, drunk people at night. So we would like to highlight that danger and identify the risk factors. You can see here our clinical question and our PEFO framework, where we would like to see the association between the helmet use, the rider sex, the alcohol consumption, and drug use in case of patients who sustain maxillofacial injuries by e-scooter accidents. We conducted our search 1.5 years ago, and then we would have liked to make our topic more interesting, so that's why it wasn't correlated with the previous Prospero. So we made another Prospero registration, and we conducted the search again in June in the 4 main databases. At first, we had almost 2,000 hits, and after the selection, now we have 10 eligible full texts, and now citation chasing is ongoing. You can see here the finished outcomes, but due to the lack of time, I would like to talk about only one. You can see here the first plot about the maxillofacial fractures and helmet use. We analyzed the maxillofacial fractures in context of helmet use together, and we divided them to upper face, mid face, and lower face fractures. Our aim was to see that helmet is a protective factor or not in these cases. We could see that in case of maxillofacial fractures overall, the odds ratio was 0.2. And in case of mid-face fractures and in context of helmet use, the odds ratio was 0.13. So these were the statistically significant results. So in these cases, the helmet is significantly a protective factor. You can see here our second project progress. So as I said, we started to write the manuscript, and half of that was finished, but now we are updating, so we updated the Prospero, and now we are updating everything. You can see here my specific goals again. The first, the effectiveness and safety of the currently used methods in treatments of jaw fractures. It was submitted in March 2025, and the other one, the e-scooter project, our planned submission is in August. And you can see here my additional activities. I'm teaching at Department of Oral and Maxillofacial Surgery and Stomatology, oral surgery and implantology to the students. I got my specialty exam in 2023, and I was a presenter in many conferences. And I think the best, all in all, is to take part in and outpatient care. And I would like to end my presentation with the words of Dan Brown, that everything is possible, the impossible just takes longer. Thank you for your kind attention.
Thank you for your presentation. I have two questions. My first one is regarding your first project, which was about the interior maxilla fixation. Which one do you use at your clinic, if you use it?
Thank you for your question. So that was my aim with our study or meta-analysis. Because we use the Ricard bar, it's painful for the patient, it's so time-consuming, and I would like to change it, but we use that because of the financial background, and you don't need any skills for that, because if you use the IMF screws, you shouldn't harm the roots, so that's why we use the Ricard bar, but I think mostly financial background.
Okay, thank you. And my second one is about your second project. You mentioned that helmet is a serious protecting factor. What type of helmet, like a bicycle helmet or something more serious that could protect against the jaw fractures?
It's really interesting because the articles didn't mention what kind of helmet they used. However, it's the most important thing, I think. So they should use the full-face helmet, but I don't really know who's going to be the person who's drunk and would like to go home at night with an e-scooter. And the first thing is that, oh, I don't have a full-face helmet, so I won't use the e-scooter. So I think they won't use it if it's needed. So I think it wasn't mentioned, so it's a limitation of our study, but I think maybe the bicycle helmet was used, but they need a full-face helmet,
okay,
as the motorcyclist has.
Thank you so much.
I've never seen anyone with a full-face helmet on a scooter.
Me neither.
Yeah. If you go back to the last slides, one of the last slides with the second study, yeah, here. So what do you think, why you cannot see the protective effect of the helmet using the lower face and upper face fractures?
Thank you for your questions. I think in case of lower face fractures, because what we have talked about, because the bicycle helmet doesn't protect anything from the mandibular fractures. And I think the most common, as I see in our clinic at night, that they fall into their chin, and that's why they are going to have a paramedian fracture or condylar fractures. So that's why it doesn't a protective factor in these cases, because only the full-face helmet could be a protective factor, but they don't use it. And in case of upper face fractures, I think they are the least common fractures, and the helmet can protect from two ways. But I think the frontal bone is really hard. So I had a frontal bone fracture, and there was no need for surgery, and it's really hard. So maybe the mandibular fractures and the mid-face fractures are more common. For example, the maxillary sinus and the orbital wall can be fractured so easily.
My problem is with this entire story is that I don't think that we need evidence that the helmet is good. Do you agree?
We would like to see that in which cases it's good or it's a protective factor, and we would like to highlight maybe that there are many fractures with helmet as well. So,
as you mentioned, the most fractures occur with the drunk young people at night. Am I right?
Yes.
Do they use helmet?
No.
Yeah, that's my point.
So another that you have not mentioned, that whether they are using electric scooters or classical ones.
Electric scooters.
So
I mentioned, yeah.
Because
so in our study, everyone uses the e-scooter. Mm-hmm. So the electric one.
Yeah, because in Hungarian data set we found the depth difference between these e-scooters and not e-scooters. And my other question is about the first study that in the iatrogene injuries, what was the effect size measure? So it's...
So with the continuous outcomes were the mean difference, and with the dichotomes was the odds ratio.
But in this case, so you have the how many injuries you have, or somebody has an injury, no injury? It dichotomous was, or it's a...
It was dichotomous.
And you used an odds ratio or a risk ratio?
Odds ratio.
What the odds, and why? Why not a risk ratio? Could you show the next slide, please? So these are odds ratios, not risk ratios. Okay. I'm asking it because in the network we're typically using the risk ratios because the odds ratios could be larger than typically than the risk ratios, and it could be show a little bit confounding effect. Okay, but if it's an odds ratio, good. Okay, thank you.
And I guess all of these studies were RCTs for the network meta-analysis?
We made so Noemi Gede was my statistician, and she made them for only RCTs and RCTs with non-RCTs combining together. But in the main article, we used the RCTs only because it has a highest power, so its power is better.
All right.
And we should use in network more RCTs, so it's recommended.
All right, I will ask some maybe methodological question. If you go back to the selection flow chart.
The first one or second?
The first one. Yes, that one. What do you mean by 23 plus 6? Could you tell us what is these 6 articles?
Yes, we didn't make another flow chart from the citation chasing and references, but we have the whole flow chart at the manuscript. So the 23 eligible full texts were the selection procedure, and the 6 plus were from citation chasing and references. So 5 from citation chasing and 1 from the references.
All right, and I didn't really get, why did you register a new Prospero for the second study or the first study? You mentioned you had to do another Prospero for one of the studies.
Yes, because we have registered it 1.5 years ago. We made the whole search, and then we have the data. So at first we would have liked to see the prevalence of the fractures and so on. And then we had another talk to Gergő, the statistician, and he said that it's not so interesting in this case, and we should make comparisons, and we should search for articles where we have 2 factors compare with each other. So that's why he recommended that, and that's why we needed another Prospero because we can't correct it in this way because it would be a major correction, and in Prospero we can't do that. So that's why we dropped it, and we made another search again.
All right, thank you.
Naturally, after the Prospero was registered, and it was finalized and accepted.
One more question for your second study. So you mentioned several times that night and drunky people. There was any study that made more complex analysis with adjusted method or something to include more factors in this?
They were mostly observational studies, and they have written that we had patients between this time interval, but we couldn't analyze it, and we have not exactly the same data, so we couldn't do an analysis. And it's really important with this e-scooter topic that we don't have a huge amount of articles in this topic because it's quite new. So that's why we didn't have a lot of data, but we are trying to work with that, and that's why we couldn't analyze. But I think after 5 years we could make another search, and we could write it down that which are the time intervals. But it depends on a lot of factors. For example, if you have an e-scooter accident on the street, you are going to the emergency department at first, and after that, if you have a CT and they recognize that you have an isolated maxillofacial injury, you can come to our department. But they sometimes have, for example, intracranial bleeding or brain injuries, and it's the first thing to cure, and after that comes the facial fractures.
Do you know that there is any force to write down the information about the helmets in Hungary? Because as I see, there is in the emergency unit, they don't write that whether somebody wear a helmet or not.
We are trying, but I don't really see that they would like to make the rules for helmet usage, but it would be better because many injuries happening, and only some part has only maxillofacial injuries from that, so a little percentage, I think. So it's maybe combined. So I think they need, but they should use the full protective helmet, and I think that it's not reliable to use.
Thank you.
So I wanted to ask you, are you aware of any evidence of potential harms by wearing a helmet while driving these scooters?
I think it has more advantages than disadvantages. At first, I think it can protect your brain, and it's the most important. So I see the maxillofacial injuries, but I think the most important is to protect the brain. And after comes the facial injuries. I don't think that it has any disadvantages to use that, so I think it's a protective factor.
Okay, thank you.
I'll just have a quick question regarding your first project. First of all, congrats for your presentation. So about your first project, was there any particular reason you have only chosen adults with these injuries?
Yes. So with the first project, that's what you think about. So our population were the adult patients. It's really easy that in case of children, we can't use the titanium plates and the screws because the bone growing or the skeletal growing is in progress and it's not ended. So that's why if we need the surgery, we should use the non-resorbable plates. And the splinting method, it's really painful for them, so it's not a good procedure for an adult as well. So that's why that's why the splinting is not a common method in case of children.
I see. Thank you.
Thank you for your presentation. Why did you choose the network method for your first project?
We choose the network method because we have 3 arms. And we can use the network method if we have more than 2 arms. So we would have liked to compare the 3 arms with each other, and it's a higher quality. Yes, and we can pull the direct and indirect comparisons as well. And in case of some outcomes, we don't have a direct comparison or articles for direct comparison. So that's why it was a better method.